Welcome to our scrutiny panel meeting for healthy adults and older, healthier community. I think we should start off today by introducing ourselves because we've got two new panel members. We've got our young inspector and our youth participation worker who is here to support her. So I'm going to start, we'll start off on here and then we'll go around just to welcome them both because I think it's fantastic that they're actually joining us. So my name is Councillor Agasaki Gina and I'm the chair.
Good evening, Councillor Jennifer Gould, Vice Chair.
Councillor Caroline Charles.
Hi, Councillor Sławek-Szczepański.
Hi, I'm Councillor Lakshmi Attawar.
I'm Councillor Martin Welton.
I'm Councillor Max Austin.
I'm Councillor Eleanor Cox.
I'm Councillor Peter McCabe. I'm not a member of the committee. I'm the Cabinet Member for Adult Social Care and Health.
Thank you. I'm Keziah. I'm a participation and engagement worker, and I support young inspectors.
Good evening, everyone. My name is John Morgan. I'm the Executive Director, Adult Social Care, Integrated Care and Public Health.
Good evening, I'm Mike Proctor. I'm Director of Transformation in the Merton Wandsworth team of the South West London Integrated Care Board.
Hi, good evening. I'm Dagmar Zona. I'm Director of Public Health here in the Council.
That one. Hello, my name is Vanessa Ford and I'm here tonight in my role as the Chief Exec for South West London and St George's Mental Health Trust, but I'm also the Merton Place convener.
Hello, I'm Priya Samuel, Integrated Partnerships Manager for South West London St George's Mental Health Trust and supporting Vanessa.
Good evening, I'm Stella Akintan, the Scrutiny Officer.
We've got Lola online, so if she wants to say a quick word, that's fine. If not, we'll just carry on.
Hi everyone, I'm Lola. I'm a young inspector for Mental Council.
Welcome, Lola. Right. Any apologies?
Chair, we've had apologies from Diane Griffin, co-opted member.
Declarations of interest? No. Minutes of the previous meeting? Agreed? Okay. I think we're on number 4, where we will be listening to Vanessa, enlightening us with the impact of the pandemic on the mental health. So if you're ready.
Okay, thank you. And thank you very much for inviting us to join you this evening. So as I introduce myself, my name is Vanessa Ford, I'm the Chief Exec, and I'm also a mental health nurse by background. And South West London and St George's has been part of my life now for the last 24 years. I trained there initially and is very committed to the South West London boroughs. So tonight I've been invited to speak to you particularly about the post-pandemic impact, COVID impact on mental health, but I'm going to cover a little bit broader than that. I think I've been asked to speak between 5 and 10 minutes, which is what I will do, but I know that you have an extensive report within your packs that you may want to ask me questions on. So I'm going to present on delivering the quality of care, collaborative working, the risks that we have to delivery, the Gelpins Road incident and the support we provided across the system at that point, our transformation, and then finish with some key takeaway messages. So if we can go on to slide 2. So just a brief part about our trust. We serve a population of 1.2 million. We employ 230 2,379 people from across our 5 boroughs, and we really are strongly committed to becoming a even better anchor institution, and we were one of the first to pledge to pay the London living wage. We have over the last years, we have over 400,000 contacts with service users in any given year, and deliver care to about 20,000 people. And just the fact that I wanted to draw out here, we only admit 1,695 people. Now that admission for those 1,695 people is very poignant for them, and significant, and represents a restrictive, effectively a restrictive intervention. So shouldn't be underestimated, but it is by no means the biggest part of the work that we do, because wherever possible, we treat people within their local communities. We have 120 clinical teams providing care at any time across inpatients and outpatients and community services. They're separated into acute urgent services, community services, our CAMS, child and adolescent mental health services, which I'm not going to talk about in detail here because I'm very aware that you have a separate scrutiny committee that covers children and young people. And yet, if we don't look at mental health as a whole and think about the preventative impact that we can have by getting our children's mental health services correct into adult years, we will be I would be missing a point if I didn't highlight that. So I am, of course, happy to answer any questions on our child and adolescent mental health services. If we go on to slide 3, I tried to think about, if I was a resident of Merton, what is it that I would want to know about my mental health services? So I would want to know that the mental health services across the board have a very strong care quality commission rating of good. And that's across all of our inpatient services. I'm delighted to let you know that our rehabilitation services and our eating disorders services have both been re-rated this year and both been re-rated as good across the board. I'd want to know that actually, on average, 80% of all patients in Merton receive treatment within the 18-week referral to treatment time. And 85% of people who've used our services would recommend our services to friends and family. In terms of demand, the demand post-pandemic has been significant. We did see a dip during the pandemic itself. Not that people didn't need us, but people weren't coming forward as much. But we've since seen our stats increase to above pre-pandemic levels. So we've seen a 40% increase in referrals for working age adults in the Merton teams. We've seen an 8% increase in referrals in our Merton child and adolescent mental health services. And we were asked a particular question about whether we had seen any increase in self-harm. We did see an increase in self-harm for children during the pandemic, but it now appears to have gone back to pre-pandemic levels. But often that can be masked by secondary presentations in a different sphere. We've also seen an increase in the number of young people presenting with eating disorders, and that increased during the pandemic and has not reduced. In addition, what we are seeing is a number of young people coming forward with what we would call disordered eating. So their primary diagnoses may be of a different mental health condition, but they have disordered eating in parallel, which makes things much more complex. And then we've seen a 6% increase in demand for acute services, so for our inpatient facilities. Do you go on to the next slide? So we don't deliver services in isolation. So I'm talking to you tonight about the mental health services provided by South West London and St George's Mental Health Trust. But obviously we can't do that without the integrated care system. So without primary care, the voluntary and third sector, and our colleagues in obviously the local authorities. And we're really actively engaged in developing the new mental health strategy for South West London, which will have a strong emphasis on community needs and tackling health inequalities across the board. So I'm really excited about that piece of work. In addition, South West London and St George's has committed very strongly to working towards becoming an anti-racist organisation. And I use the word towards particularly because actually it is a journey that we all have to go on together. And we also have strong relationships, not only in Southwest London, but also in across the South London Partnership, which is made up of Oxley's and SLAM, the two neighbouring trusts in South East London. And the reason that's particularly important for this committee is to be aware that we provide highly specialist services for forensics, eating disorder, forensic patients, eating disorders patients, and those child and adolescent inpatient services, which means that we have been able to provide care much closer to home. So this time, 3 years ago, the average distance that a young person would travel for a psychiatric intensive care bed, which is the highest level of bed, was 70 miles. That's now down to 7 miles. Which is a significant improvement. Likewise, forensic patients, we've managed to repatriate from out of London over 158 patients and then move those monies to follow those patients back into the community. Again, our commitment to reducing restrictive interventions. So if we can go on to the next slide, that's it. No, how am I now? I've done that bit. So in terms of cost of living support, as you will be well aware, our patients, or our people in particular, are very vulnerable to the impact of cost of living. So we have worked really hard with local organisations to think about the best way in which we can support people to overcome these challenges. In particular, our Merton Uplift, which is the IAP services, have been working around employment, and many of you were involved in the South London Listens programme, where we have worked on the preventative agenda, and Merton has 10 wellbeing Be Well hubs set up. You're the largest number of Be Well hubs across the 5 boroughs that we serve, so thank you for that on behalf of the people that we serve. If we go on to the next slide, please. So risk to deliver, our risk to delivery. So the most significant risk to delivery, I would say, are twofold. There's the demand and the flow through our system. So particularly for our inpatient beds, the number of people that we are having who are detained under the Mental Health Act has increased. That leaves with it an increase in complexity. And then the number of placements that are available for those people back out in the community with the complexity of needs is very difficult to find. And that then causes a challenge of the flow through our system for our most urgent and acute end. In addition, what we're seeing is the needs that people are coming forward with in terms of housing, accommodation, work, meaningful employment, alongside cost of living, and then their mental health condition on top, is also impacting on our ability to support people in the most effective way. That is not a unique picture for South West London. It is a picture across the capital and across the country. Recruitment and retention is our next biggest challenge. So we're holding a vacancy factor of just below 18% at the moment. So it is very significant. And that is without taking into consideration sickness and absence. So the way in which we are addressing that is we're looking at the development of new roles. So we've had some great new roles come in terms of peer support workers, new advanced clinical practitioners, non-medical prescribers, all different ways in which we can provide care and treatment. We're also looking at how we can support and invest in the third and voluntary sector to support our services in a different and more sustainable way. But there is no quick fix, I would say, to the recruitment and retention challenges that mental health trusts in general are facing. And then across our urgent and acute area, actually the importance of people seeking early help and not getting to a point of needing admission. So the prevention agenda in particular is key to this. So we're working on creating an NHS 111 Press 2 for mental health to bring parity for physical health and mental health. And South West London and St George's has in fact been the pilot area for that for the whole of the capital. So if we go on to the next slide, please. I guess I just wanted to highlight, obviously following the tragic incidents in Galpin Road, actually the work that we were able to do together and collectively to support the local residents, I think was really a positive outcome of a very difficult situation. And I just wanted to highlight and to thank the collective response of people, and actually to note that the psychological trauma from that incident is going to stay with that community for a long time. So actually we're not there overnight. We weren't there just for a couple of weeks. We're there ongoing, providing ongoing support without pathologizing what is also a normal reaction to a very difficult set of circumstances. If we go on to the next slide, please. So transforming our mental health services. So today, I was very proud to walk through the corridors of our brand new mental health facilities based up at Springfield. They have been created through the sales of the land and the rejuvenation of the site, including the largest park since the Olympics here in London, which is something to be quite proud of. But that means that your residents will be and your people will be cared for in some of the best state-of-the-art facilities, alongside the redevelopment at Springfield. We're looking to redevelop both Barnes, Richmond Royal and Tolworth Hospital. And that is all done within the Trust's own finances. And we're working very hard to make sure that Wilson is the Wilson service is not left out of that regeneration. And I know we've got positive plans in place, because mental health services are were the last men standing on that site for some time. So that was important. But alongside the estate, we're also creating new community pathways to support community transformation. And Merton will be the borough that goes next year to transform the working age adult services. But we also have plans to further develop our CAMS and our older people's services. So in terms of the final slide, I think if I'm lucky, oh, there's some pictures of the hospital. Couldn't help but put them in. Keep going. There we go. And our award-winning art. So this is it. So this is what our new community transformation pathways will look like. In effect, there will be a one-stop shop where you'll be able to go get your assessment, and then will be either signposted back out to other services or straight into clinical pathways, all of which will have evidence-based care in them. And then the final slide, then hopefully. There we go. So key takeaways: we're under significant pressures. This isn't just a local issue, it's a national issue. We're working really hard to collaborate through the new integrated care system, because actually this is not just for the Mental Health Trust on their own to solve, it's for all of us to be involved in, and we take our responsibilities very seriously for that, not least because I chose to be the exec lead and the convener for Merton Place on purpose. We are strategically tackling health inequalities across South London, something that we care passionately about. And as I've already told you, we're investing in state-of-the-art facilities which will serve the people of Merton as well as the other 5 boroughs. So I think I've probably taken up 8 of my 10 minutes, hopefully not longer, and I'm happy to take any questions.
Thank you, Vanessa. Ellie.
Thank you very much for that. I found it really insightful, and forgive me if I don't know a huge amount about this. So I'd love just to know a bit more. So you mentioned that obviously during COVID that this has caused a spike in the amount of mental health referrals. I understand the challenges that you face very clearly from your presentation. But what is it that is actually at the root cause of that can actually help bring them back down to pre-pandemic? Because whilst I know you're trying to build capacity, is there something else that we could be looking at as well to try and help bring that back down?
I think we'd all love to know what the golden bullet is to bring it down. But I suppose in short, what I would say, so if I was a young person and I was trapped at home with my parents, who I did love, trapped at home, I had no control over anything else. My mum might have been going to the hospital every day to work, and I was frightened every day from the media that she was going to come home or not come home and die. I think we can understand the anxiety that would provoke in a young person. I think actually that anxiety echoes through what many of us experienced in our families during the pandemic, and different people have different ways of expressing it. So I think the underlying anxiety and reaction to COVID, some of which is very normal, it's a normal human reaction. But actually, if you don't have the mental resilience to carry that through, then that actually leads to an increase in the need to seek mental health services. So it could be a secondary area. I think we've talked a lot in the Merton Place about building resilience within our community. So how do communities support and look after each other? I think there is some of that, but I also think that for a number of years, people didn't, it's 2 years, if you think about it, where the pandemic lasted for, when we were told to stay away effectively, unless it was urgent. There was a level of neglect that crept in for people who were vulnerable. And that level of neglect is going to take time for us to recover from. And I think that was on top of the fact that actually mental health and well-being has raised its profile. So a number of years ago, I'd never been asked into a forum like this to talk about mental health. So actually the fact that it's been spoken about in society, the fact that people feel able to come forward and ask for help is a really positive thing. And yet that creates a challenge in itself. I think later on the agenda, we have papers around suicide prevention. And one of the comments I would make, I fully support everything that's written in the paper, but actually what do we do to create mental health and wellbeing resilience within our communities, as well as prevent suicide? They're two things that sit alongside each other that we have to consider.
Thank you very much, Vanessa. It's a really insightful talk you gave us just then. What I would like to ask you about, you mentioned eating disorders or disorderly eating, but what help there is in Merton for that, and whether maybe something could be done with the Wilson Hospital, as I know there's quite a lot of mental health help there, but particularly for eating disorders. And also, could you just explain, if a patient turned up at St George's Hospital, say, and presented there with eating disorder, obviously a severe case, what exactly happens? Is there somewhere that is there a separate ward, or is there a mental health team? How are patients helped with that? Thank you.
Okay, so first of all, we offer specialist eating disorders treatment for both children, child and adolescents and adults. There are 2 different pathways, but they sit in parallel to each other. So if you went to your GP today, you could get referred to a specialist service. Those specialist services are located in hubs. So we have a hub, the main hub being at Springfield, but we have spokes out into Wilson and different into the different boroughs that we serve. So people will get seen. If an individual needed more intensive support, we now offer intensive outreach support. So we've been able to generate that through the work across South London Partnership to bring by reducing the number of inpatient admissions to increase the number of community offers on an intensive basis, because wherever possible we want people to stay at home. We also have day treatment for adults, but we don't have day treatment for children. We just offer intensive child support. Children are, and in particular, and adolescents are seen within 5 weeks if it's an urgent referral, and that is within national timescales. if if anybody of any age presented to St George's Hospital, if they were presenting because they had physical health conditions connected to their eating disorder, then they would be treated through the physical health route, and we would provide psychiatric liaison support into the hospital, to the acute hospital. If they were presenting primarily with mental health conditions, then the consideration would be, would a generic acute bed be appropriate? So is their eating disorder at a level where they need a specialist bed? If that was the case, then we would consider an acute admission. If they needed a specialist bed, then they would be assessed for a specialist bed, and we would look to find the nearest available bed across the South London Partnership.
Oh, yes, thank you, Chair, and thank you for your report. I was just going to query, you're saying that patients who are referred most are seen within 18 weeks. Now, that seems like an awful long time to me. Surely their situation could deteriorate during that length of time.
So the health requirement is referral to treatment within 18 weeks, and we're meeting that. I agree. Actually, if you have a mental health condition, it would be much more ideal if you could be seen more swiftly and receive treatment more swiftly. Unfortunately, our resources don't currently enable us to see and treat people more quickly than that. If there's an urgent need, then that urgent need is met. But if the need is not urgent, but for that individual is important, then there are waiting times, just as there are waiting times for all health conditions. That's the honest approach.
Thank you very much for that very interesting presentation. I understand from some of my colleagues who had a meeting with Mr. Morgan, I think last week, that the NHS are looking to save £140 million across southwest London. And I wonder if you could say something about the effect that cut's likely to have on your services. Thank you.
Well, £140 million is a lot of money, isn't it? And part of the integrated care system means that we work together collectively to ensure that we provide health, both physical health and mental health care as well as we possibly can. Mental health services are protected in terms of their investment through the mental health investment standard monies. So actually as part of the levelling up agenda for physical health and mental health monies has been to some extent protected. That does not mean that I don't have a part to play in the system's recovery from finances. And I think there will be a significant challenge in us ensuring the sustainability of healthcare and those costs. In fact, I've been in meetings this evening talking about how we do that as safely as we possibly can whilst maintaining services. And the large focus of that will be looking at productivity to ensure that we're providing care in the most productive and effective way that we possibly can. But I will leave the wider question around how the ICS is going to make its savings to another day. But I'm sure my colleagues would happily come back and talk to that.
And Chair, it would be very helpful if we could hear, I think, how the 140 is going to be saved across the NHS in this part of London.
Thank you, Chair. You mentioned mental health strategy development. Can you explain how are you working with voluntary sector organizations to shape the strategy and reduce the inequalities? And also, in terms of the cost of living crisis and the pressures on families, are you seeing hikes in demand? And if so, how this will impact the strategy?
Okay. Thank you. So the South West London strategy has been product of a large period of consultation. So we've gone out to the Borough of Merton through Dagmar and John and other colleagues, we've engaged with the third and voluntary sector. We've held face-to-face engagement events, online engagement events, surveys. Really pleased with the level of engagement and thought that people have given to that. So we've had over 700 responses to our surveys that have influenced the strategy thus far. It's currently back out to consultation. So I was at the Merton Health and Care Together board today, where I spoke about the strategy and agreed that we would circulate it again for consultation before the final version is submitted to both the Integrated Care Board and the Integrated Care Partnership, where obviously the social care sits. And you asked me about cost of living. I think it's too early for me to say about the cost of living impact. So I would say that some of our most vulnerable people will have mental health conditions, and they won't necessarily make the right choices during this difficult time because they will be frightened about what will happen for them and what they can and can't spend money on. But I don't believe that we have seen the impact of that. So much like with the pandemic, the COVID pandemic hit us kind of a year after the physical health pandemic. And I think we will have a similar impact around cost of living, because we know, for example, the impact of financial pressures have on things like suicide. So I think we've got a journey to go together before we understand that fully.
Yeah, thank you for your presentation. In your presentation, you said you've reached a 80% success rate. I just wondered who makes up and why the 20% failed that. And also, there are people out there who don't always come forward and need assistance. What can you do to try either to go to them or to get them to come to seek help when they need it, but are reluctant to seek help?
Thank you. So I said that was 85% of people would recommend us as somewhere where they would want their family or friends to be cared for. I'd love to know what the other 15% thought, so I could go to them, but it's a anonymous survey. But what I would suspect that not everybody would ever want to receive mental health care and treatment because there's still a stigma attached to it. But actually, people don't always have timely care and treatment, as your colleague spoke about. Some of our waiting times are significant. Sometimes people have difficult experiences with us. And I think also that point that you raise around not everybody wanting to come forward for help is really significant. And that's why the more work that we can do around community resilience, the more work we can do around reducing stigma, and also helping other people to identify signs like the mental health first aid workers, knowing where to post people to for early help and treatment is probably the key.
Thank you. Can I firstly thank you as a councillor for Pollards Hill for all your work in terms of Galpins Road. It has been hugely challenging for the whole community since that terrible tragedy last August. It will, as you said, take a number of years for people to get through the trauma of that incident. And it's obviously a continuing thing for many people down there, given it was so many families and people were impacted by those tragic events. So that's a personal thank you. My question obviously is in relation to your vacancies. You've obviously said 17%. Now, clearly, that's an issue across the National Health Service in terms of the level and in terms of the numbers. Can I ask how many are being recruited from abroad in terms of helping to fill these vacancies in our hospitals, given we know that recruitment is a continuing challenge and will continue to be? And do you envisage that the number of vacancies will reduce, or is it likely to get worse?
Well, I have to be an optimist in my job, so I very much hope it's not going to get worse. But what I would say is that the work that we're doing around redesigning our workforce, so thinking about different types of roles, thinking about our role as an anchor institution, how do we get people involved and thoughtful about mental health earlier, what professional registrations do people need versus actually what skills do people need, and how can we teach and train across that, I think bodes well for us. So for example, we now have a number of nursing associates, which is a role that sits just below a registered nurse. They're still registered on the NMC registration. They can just carry out different roles. We didn't have those 4 years ago. I've now got over 30 people in those roles. I employ 700 nurses, so I've got a long way to go, but actually skill mix is one way of doing it. That doesn't necessarily mean people receive less care. I have to be really clear about that because the standard of care can't be deteriorated. Am I actively recruiting from abroad? At the moment, we have a campaign abroad for special registered doctors, so the level below consultants. We aren't carrying out any other campaign for nursing at the moment. We did do something across the capital last year, but actually the numbers were very, very small, and the return on investment, for want of a better way of looking at it, was less than actually working with the local population that we serve and thinking about the care that we can provide. So I'm forever hopeful that it won't get worse. I fear that at the moment, in particular with strike actions and the impact that has on how people feel about their roles, that could be significant, but we just have to work with.
I'd like to come back to 3 questions. I know you said somebody will come in and discuss about the money, but I'd like to ask about it. It's 140 million that you've got to save, basically, isn't it? How much of that is that budget against the mental health trust, and how will it impact on Merton residents? That's one question.
Yeah.
What services will you need to cut? And how can you meet the shortfall? And at at time of rising needs, are you worried that you will not have the resources to meet the needs of the Merton residents? Because we're always saying about outreach. We haven't got enough beds, so we'll do outreach. But I always find there isn't enough resources for outreach. So how are we going to cope with that? Because as you say, mental health has risen an awful lot in adults and in children. And that's at the moment, schools can't even get CAMs to come and see the children. So we have a real issue. So how will it impact Merton residents, and how much of the money is going to be lost? I know you said it's sort of a ring fence, but I don't believe anything's ever ring fence.
So I would start by saying that the financial position of South West London is significantly challenged, and we are working through that together as a system. And we will come back. I will come back to, or someone will come back to you about the wider 140 million. What I would say for South West London and St George's is, like all NHS trusts, we have a cost improvement plan and target. At the moment for next year, that's looking like £6 million. We may well find that through non-recurrent savings. At the moment, I don't have a recurrent plan in order to find those savings whilst maintaining my current level of service. And at the same time, because of the mental health investment standards, there will be investment made in mental health next year. It will be the only area where investment is made, and that is ring fenced. And I should know, but I can't remember on the top. Got starstruck now, the exact number, but I can come back to you with what the number is. And that isn't going to resolve the pressure that people feel. And some of the challenges that people feel, both staff and families and carers. But I would say that my services are responsive. My stats show that actually our services do go into schools and see people. We do see children within the right timescales. And at the same time, that may not be as quickly as everybody would like it to be.
Thank you for that. But, I went to a school yesterday discussing, because I'm a special needs governor, and some of the children cannot get to see a CAM worker, which before, I think last year, CAMs were doing very well. I must admit, they were getting to see the children. It sort of ramped up, but now it seems to have gone down again. I know there's resource issues, but as you say, this is a very important issue, and we need to actually do something about it and try and get things sorted. I know there's financial burdens, but I think mental health is very important. And I'm wondering about the wonderful land that's been sold. Are we getting any money from the money in Springfield? All those wonderful villages being built. Are you getting enough money? You should have got enough money to be able to support the hospital.
So all of the money from the land sales has gone back into the estate. It hasn't gone in. We're not able to use capital land sales to fund revenue business. I'm very happy to explain to talk through that outside of here. And I'm really sorry to hear the experience that you're recapping. Perhaps you could let me have outside of here the name of the school, and we can look into the concerns that you have raised.
I will do.
Thank you.
Anybody else have any questions? No? Thank you very much. We are now on to the long COVID. Mike.
Thank you very much, Chair. Are we putting the slides up now? Okay. Okay, you've got them in the pack. Okay, so good. I shan't go through the pack in detail then. I shall just pull out a few of the highlights. What the report in the pack illustrates is, first of all, just a brief recap of what long COVID or post-COVID syndrome is, the symptoms, and one of the things about long COVID is the symptoms are fairly general. There are things which could well be associated with lots of other conditions, and long COVID generally turns out to be what they call a diagnosis of exclusion. That is to say, once you've seen someone with these sorts of symptoms and you can't give any other explanation, and they have had COVID, although you don't need to have had a diagnosis of COVID to be regarded as having long COVID. In most cases you do. The common symptoms are really fatigue is the main one, followed by breathlessness and brain fog. But there's actually a whole suite of symptoms, and it's the combination of them which often gives the clue to the fact that this is post-COVID, but specifically the fatigue. One of the interesting issues is the prevalence of long COVID. There have been, because it's a difficult to define disease and difficult to diagnose, and therefore slightly elusive, what the actual prevalence is hard to say with absolute certainty. So the epidemiologists have done various calculations, and I suppose the punchline is that although we're not entirely sure what the prevalence is, we're almost 100% sure that the observed presentation of symptoms and those coming forward for treatment is well below the overall prevalence. So we estimate that within this borough there'll be something over 4,000 people actually have post-COVID, but we certainly don't have that number coming forward. And it's those differences between certain elements of the population of the degree to which the prevalence is underreported in terms of those coming forward for treatment, that I think is one of the interesting things. In page 46 of your pack, you'll see a rough outline of the model for the support that we provide to people within Merton and Wandsworth. The service that this paper describes covers both of those two boroughs. And at the lowest level, it's just about help and advice, and then going up through to help with the GP. The heart of the service is the borough-based PCAS. So this is where it's actually the main service which treats people and directs them to other services and support. There is a more specialized level of support above that, but that's when there are aspects of the condition which are related to a specific part of the body. It could be a cardiological issue or a respiratory issue where you need to see a hospital specialist, a consultant. Most of the services provided at the PCAS level, where we can work on a more general level, and that's a therapist-led service, which has got very good feedback on all of the customers, or satisfaction service, if you want to describe it in those terms. The next page in the poem shows the actual pathway, which is a bit of a wiring diagram, but it's just to illustrate the fact that depending on, because of the wide range of conditions and manifestations of problems that patients have, that we can treat those in a number of different ways by directing them to the specific services which will help them. And an important part of the model is that if people are discharged from the service, but then problems recur, they can be automatically passported straight back into it without having to go through a re-referral. They can go back into the service. So as I mentioned earlier, one of the interesting things is we know we're not seeing everybody who has post-COVID. So which are the groups which are underrepresented? And a lot of the report you'll see is about where we've examined the figures on ethnicity, on age, on deprivation, and compared our figures with what perhaps you might regard as the numbers we should be seeing if everyone came forward. And on page 49 of the packet describes the health equity audit, and the methodology is then to look at the observed numbers that we have coming forward and are recording, and compare them with, if you like, the theoretical numbers if we had everyone who we think we should have. And there are two things. One is there is quite a variation, and I'll pick out a couple of the features of that in due course. But the overriding headline message is that whichever indicator you look at, we're well below, a long way below what the prevalence suggests we should be seeing. And it's one of the challenges is how do we try to encourage those who need help to come forward and seek it. So you'll see on page 50 of the pack, there is the breakdown by GP practice. So that gives you an idea of whereabouts in the borough most of our work is coming from. And you'll see a big variation in referral behaviour between GPs. And we are trying to work with GP practices to make sure, because certainly those with very low referral rates, that there must be some patients who are being missed. Some of the trends within whereabouts in the borough most of the patients coming from, I think, are picked up in the later slides around the demographics. If we look at the reported presentation by between males and females, it's expected that on the national data that you would have more females coming forward. Nobody quite understands why that is, but that is even more pronounced in Merton, and we're not sure why men are less likely to come forward. But I think that's probably just the general, not something that's specific to post-COVID, but a general observance that men sometimes aren't as good at coming forward with any sort of health problems and seeking help. In terms of the age, compared to the national figures, in Merton, we're seeing a slightly older cohort. The typical sort of cohorts that may come forward tend to be female, as I've just said, but also middle-aged. That sort of it's more the later end of middle age that we're seeing in Merton compared to the national trends. An interesting one is around deprivation, where one of the issues we have in Merton is that it's almost reverse of what you would expect from the national trend. So the national trend follows the trend of COVID itself, as well as post-COVID, where the more deprived areas seem to have a higher prevalence, whereas we don't quite see that in Merton. And that gives us the clue that we need to do more work, and are doing more work in the more deprived parts of the borough to try to encourage people to come forward and to raise awareness that if they're just feeling a bit tired or a bit out of sorts, there may be more to it than just you know, the fact that you can sometimes feel like that for a number of other reasons. In terms of the ethnicity, broadly in Merton, we're following the pattern that you would expect. If anything, it's actually the white population who are possibly slightly underrepresented in our service, but that's fairly minor. So the last couple of slides within the pack or within the report are about what we're doing to increase the uptake, to increase awareness, to make sure that these groups who seem to be underrepresented, that we can get through to them, make them aware of the service and get them to come forward. One of the interesting things is that although this service has been running for more than 2 years, the rates which people come forward have been remarkably consistent at around about 10 to 15 new referrals per week. And that's hardly changed across the last 2 years, despite all the work that we're putting in to try to increase awareness, both in terms of practitioners, so you know, GPs seeing people with some fairly general symptoms, picking up on the fact that it could be post-COVID, but also the patients themselves, to make them aware that this could be the issue that they're facing. So I won't go through them all, but there are a number of initiatives that we're continuing to work with our GPs, with our social prescribers, with the PCNs, those are the groupings, of course, of GPs, but also colleagues within the council and specifically public health, who have been very active and supportive in terms of the work that we've done on post-COVID within Merton and Wandsworth, but particularly Merton, I have to say, particularly Merton. We're trying to make the routes for referral easier so that people can gain easier access to social prescribing, and also so the IAPT services that the Mental Health Trust provides. And again, they are very active parts of our local Merton and Wandsworth post-COVID group, because the mental impact, and Vanessa could talk about this more than I can, of having this debilitating disease that just drags on and on, can be very difficult, and the IAPT service have been involved right from the start. We have been presenting to forums such as this. Anyone who wants to hear about this, we're happy to tell them. And an important part of that is the patient story that we're developing, because I think that's more powerful if we can describe the journey from the point of view of someone who's actually been on that journey. So a lot of work going on in terms of communications on social media, peer support groups, websites, etc., to try and raise awareness, to encourage people to come forward and to seek help. Because the last page in the pack, which is just one particular patient testimony, but this is typical of a lot of the feedback that we get about the fact that the service actually is good, is helpful, but we just need to encourage people to come forward and to take advantage of that. So I'll stop there, Chair, and ask if anyone has any comments or questions on any of that.
Martin.
Thank you for your report. Obviously, it makes fascinating reading, especially obviously that COVID continues to be a challenge. We know obviously it's obviously not profiled in the news, but there's still large numbers coming down with COVID, and there's obviously always the risks of new variants out there as well. clearly, obviously, it's not as bad as it was, but it will be a continuing problem for the National Health Service for many, many years to come, given the numbers which were impacted by the pandemic. Can I just ask, obviously, in terms of the numbers here in long COVID, how does it compare with other areas across London in terms of the numbers that are, being referred? Is there big variations between areas or not?
Sorry, the variations aren't huge. The one thing that is consistent is that everywhere the prevalence that you would expect is we're not seeing that number of people. The numbers for in Wandsworth have been fairly typical, I would say. If anything, maybe a little bit higher because we were one of the first to get the service up and running and to have had a very good service and have been quite proactive. So, but broadly speaking, I would say we're more or less in line with the rest of London.
Just obviously in terms of long COVID, how many of the people referred have other underlying health conditions as well?
I couldn't give you the actual figure, but you're right to say that that is one of the predisposing factors in terms of suffering from long COVID, which is interesting because one thing that you would expect, but which doesn't apply, is how severely ill you were when you actually had COVID. Some people who were very, very sick indeed with that, and then once they're better from that acute phase, they're fine. Whereas some people who maybe had a much milder dose of COVID as an illness then suffer badly from long COVID. But I couldn't give you the numbers in terms of those who had other health conditions, although, but that's one of the things that makes this more difficult diagnosis. Given the fairly general nature of a lot of the symptoms, and sometimes it's the combination of the symptoms which gives the clue to the fact
in terms of exacerbating.
That's right.
The situation.
Absolutely.
Thank you.
Thank you very much. Just talking about the long COVID and all the symptoms, is there any evidence that people are actually improving, or how long is long COVID for? The question. And also the services that are available, is that long term? Is it going to be a cut-off point for the services available to people with long COVID? Thank you.
So dealing with that second point first, no, there is currently no plan to for the service to stop. If anything, we're trying to promote it and push it because we are fairly sure that there is some unmet need out there. We need people to come forward. So there isn't a cut-off point at this stage. I think that as the previous speaker mentioned, COVID shows no signs of going away, even though it's perhaps at not such a high pitch, and therefore long COVID or post-COVID, whichever you prefer, will also continue to be around. And it is so there's no plan to stop the services. Sorry, what was the first point? It was about the.
Yeah, is there any evidence there's any improvement of people?
Yes, absolutely. Yes, quite a number of people are discharged from the service successfully. As we said, there is a passport back in, because with these sort of longer term things that tend to drag on, sometimes people find that there is a recurrence, but lots of people do get better, and it is effective, the treatments. Yeah.
Oh, yes, thank you for your report. I was just going to say, with long COVID, do you think part of it could be a reaction to the lockdown? Because I mean, that was kind of a really unhealthy lifestyle, people lying around at home all, for months on end, on social media all the time. That is going to create things like depression, fatigue, brain fog. If you're not active, you're just at home. And do you think that had a part to play?
Very possibly. I would defer to Vanessa as to sort of the impact that's had on people's sort of overall mental health. But the fact of not being active as well, if you're sort of shut up in the house, that obviously can't be good for you. And a lot of people who don't necessarily have long COVID or any disease like that, for example, maybe had some weight gain during the lockdown period, which obviously isn't particularly good for your health. So it may be. I couldn't say with any certainty.
Thank you very much for that very interesting presentation. I think particularly to hear that people are recovering from long COVID, because I know there's been concern that it might be like some other fatigue illnesses where people just find it very difficult to recover. So I think that's encouraging to hear. The figures that I found most extraordinary or fascinating were the ones about the different practice referral rates, where if you look at the practices with the lowest referral rates, I mean, it's a real mixture. It's neither rich or poor practices. I mean, it's a mixture across the borough. And when you talk to the GPs there, is that they're applying a higher kind of bar before they refer somebody, or they're more skeptical about some of the about making a diagnosis, or they just are seeing less patients? So I wonder what you're hearing from them.
So the usual reason that GPs would give is that because of the very general nature of the symptoms, yes, they're referring those patients, but they're not necessarily referring them to a long COVID service. So, for example, someone who is struggling with the breathing, they would just refer them to, the respiratory clinic or to a cardiologist, rather than refer them to the long COVID service. Because what the long COVID service does, as you will see, is then point people in those directions. So they end up in those places in many cases in the end. And what some GPs do, as much through force of habit, but also perhaps wanting to get their patient as quickly as possible to the care they need, just sort of, if you like, go around and say, yeah, they need help with their breathing. I think it would be therefore more just when people have that large collection of very general symptoms that they might, but I think the very low ones is when the GPs are sending them straight to a particular specialty clinic. That's what they say to me.
Thank you. I've got about 3 questions. I'm glad Simon asked that, because I was actually going to ask about this breakdown. I was going to say whether the practices that didn't have enough, had no referrals and very few referrals, is it that patients couldn't get an appointment? Because a lot of the time patients couldn't get an appointment. So I can't see doctors referring patients when you can't get an appointment. So, I mean, them telling you that they sent them somewhere else, it seems quite bizarre, actually, to be honest, because if you go through, I'm not sure if there's an app, there's a thing out that you can actually tell in the country which doctors have actually referred patients in the last 2 years, and some of these practices are there as not doing anything at all. So I don't think because they're sending them somewhere else, they're actually not seeing the patients. So I think you should go back and check for that one. It's a bit of a problem. Anyway, and could you tell me how accurate the data is about long COVID, really? I want to know how accurate the data is and how much money we're spending on the long COVID. And also you're saying that you can't get certain group, you're having to go out to advertise or tell them they can actually have this service. If they don't need it, why do you need to advertise? If people want it, if they know it's there, they'll come and see you and find you. It seems a bit bizarre to me to have to go and tell people, have you got COVID, come in long COVID, because if they had so desperately, they would actually come in.
So on that last point, the worry is that there are people who are struggling with certain ailments, but don't necessarily realize that they have long COVID, and that this is because there's symptoms like fatigue or perhaps a bit of brain fog might be something that you might not realize is a problem, and yet is actually quite debilitating. So that's why we would want anyone who needs help. Now, if they genuinely don't want help, that, as you rightly say, is a different issue. But if they want help but don't know what to ask for it, or don't actually realize what the problem is, then I think we would want to help them. In terms of the money for long COVID is one of those allocations we get from central government, which is specifically for a certain purpose, and which we have to spend on that. And we have to account for what we've spent on it. So it is actually a separate allocation rather than lost in the sort of the many millions of general funding that the health service gets. And then your other point about the accuracy of the figures, as I said when I was giving the initial presentation, the figures on prevalence are just a calculation and we don't know if they're right. The figures on presentation, the actuals, numbers of patients we see, we're absolutely 100% certain that they're right. It's what the theoretical caseload should be that is a matter of debate.
Yes, Dagmar, thank you. Thank you for that.
If I also can just add, because we discussed that, I think in the last scrutiny meeting, we have to admit we don't understand long COVID, and we're constantly learning more. Because obviously the data we have doesn't go back very long. And so as you've already heard and mentioned, unraveling in the symptoms is really a tricky undertaking. And we are actually actively contributing and trying to contribute to research, which I think is important. It was raised in the last scrutiny meeting. So we are helping to connect patients to research who want so, and we're actively in contact with researchers so that we constantly learn. So when new understandings and insights come out, that we can then adapt in a way how we are running our services. So it is an admission, a hands up, that we are not understanding this fully, but very willing to learn.
Thank you, Dagmar. Anybody else with any questions? No. Thank you, Mike. Thank you very much for your presentation. Right. I think it's you, Dagmar. Suicide prevention, please.
Could I invite Dan? I think he is dialing in remotely.
Hi there, Dagmar.
Hi, Dan. Good evening.
Good evening, everyone.
So, Chair, am I allowed to hand over straight to Dan to just give you a brief overview? Is that okay?
Absolutely, yeah.
Thank you.
Hi. So the purpose of this paper is to provide an update on suicide prevention, including services that support people and suicide prevention activity. I think it's really important when we talk about suicide to remember that each statistic is a person's life, and therefore we must obviously they leave behind bereaved families and friends. So we do need to approach this subject very sensitively. A couple of points on the context and rationale part of the paper. So suicide is not inevitable, and suicide prevention activity can really help to train those working with high-risk groups. It can support those in crisis, and it can also raise wider awareness so that people know how to get help and signpost to support. All local authorities are required to develop a plan to address suicides, and plans should have two main objectives. These are to reduce the suicide rate in the general population and also to support those bereaved by suicide. If we now move on to what the national research says. A first key point to make is that men make up the majority of those who die by suicide, and middle-aged men are particularly at risk. And there are a number of risk factors around for middle-aged men, which probably when combined together increase the risk. And these include unemployment, debt, poor mental health, substance misuse, a history of self-harm and relationship breakdown. Women are, however, more likely to attempt suicide, but conversely, that more men actually die by suicide. So I think that's an important point to make. In terms of young people, they generally have low rates of suicide, but action is still really important for this group, as suicide is one of the leading causes of death amongst young people, alongside accidents. For young people, the risk factors are slightly different, some are the same, and they include mental health issues, self-harm, substance misuse, bullying, academic pressures, abuse, neglect, social isolation, and an interesting one, which has become more, I think, more important, is a history of online use around suicide. Okay, if we move on now to the information side of the paper, the number of suicides in Merton for the last 10 years has ranged from around 9 to 20. And Merton has a rate of 6.5 suicides per 100,000 population. And that was for the latest data was between 2019 to 2021. And that's similar to London and significantly lower than that for England. And the rate has decreased slightly since 2015-17. In terms of services, we've listed those all in the appendix, but they can broadly be divided into preventative services at a community level. And these may reduce risk factors around suicide, such as the way that a welfare and benefits advice service can support someone who's got money worries. There are also, we could divide them up into services that work with those at greater risk of suicide. So suicide might not be the first thing that the service does, but it will be part of their working practice because they support those at greater risk. And WDP, our substance misuse provider in Merton, would be an example of those. And finally, we have services aimed at those in crisis or focused on suicide prevention. So I know you heard earlier from South West London St George's Mental Health Trust on the range of services and support they provide. So that's a good example there. If we then move on to the Merton's Framework and Action Plan, Merton has a suicide prevention framework, and each year we have an annual action plan with around 7 to 12 high-value actions. I wanted just to highlight a couple of projects from this year, which I think have gone really well. First of all, we've had the mental health training program. So we've trained 64 representatives from community and voluntary sector in mental health first aid awareness. And that's included people from AFC Wimbledon, the Community Fridge Project, local food banks, DWP and Faith in Action. I think some of these are quite important because obviously food banks might be one of the places where people who might be at risk, especially middle-aged men, might actually go. So I think that's why we try to target some of those organisations this year. We've also been running suicide prevention training program, again aimed at the community and voluntary sector. And we've had 86 representatives trained in suicide awareness and prevention. Has included people from Clarion Housing Association, DWP, the YMCA in Wimbledon, and those working with domestic abuse as well. Another piece of work that we've done this year is a self-harm and suicidal ideation protocol for schools and those working with young people. And this work stream was led by South West London ICB, Merton CAMS and Children's Schools and Families with obviously contribution from ourselves in public health, and included a range of other partners as well. And that's developed a practical guide for both the professionals and people in schools, as well as advice and information for parents and young people. So there's a kind of a flavour really. I think the report gives a lot more examples of what we've achieved this year, but that's a kind of a flavour. If we look at next year's action plan, I think one of the flagship projects we're going to be working on is a youth mental health first aid project. And that's going to target 16 to 18-year-olds. And it's basically, rather than people who work with young people, it's actually aimed at young people themselves. And it's about making them confident about talking around mental health with friends, peers, and family members. Again, the ability to signpost to appropriate services. So the first kind of tranche of that program is going to train 75 young people, and they're also going to train 15 adults who work alongside those young people. And the trainer will provide ongoing support for 6 months. We're also going to be developing a new mental health first aid awareness and a suicide prevention training program. So there's other key elements really. I think the final point I'd like to make is just our key recommendation from this report to members. And that's around, to really champion suicide prevention in Merton. And this could be through, promoting awareness of the support services, or it could equally be promoting and participating in training ourselves. We could put on a suicide prevention or mental health first aid training program for counsellors if that was of interest as well. Thank you.
Thank you very much. Doug, anything else you wanted to add? Okay.
Thank you.
Matt.
Thank you very much, Chair, and thank you to all who've been involved in this report. And I think I'm fully aware of how sort of sensitive each of these statistics, what they mean, and I thank you to all of you who are involved in this work. Without going into too much detail, I was pretty struck by 3.10, where it talks about the 37 individual suicides in Merton And I note that there's a double between 2019 and 2020. And I think we all know what happened or what started to happen in 2020. But according to your figures, 2019 represents the lowest part of the age range for the 10-year cycle, but it did reach 20 in 1 year. And I just wondered if you, over that 10 years, you could comment on the patterns. Are these sort of fluctuations? Even I know it's really small numbers of data, but they've, if you just take the last 3 years, 9, then to 18, and then to 10. And I just be interested to hear your thoughts on that pattern, or whether indeed the numbers are just so low that it's very easy for individual incidences to sort of skew those statistics. Thank you.
I think this obviously. I think we'll be careful about interpreting just 1 year's data. That's the first point I'd make, and I think the Samaritans, in quite a lot of their research reports, come up with that. Like you need to look at things over time, not just for 1 year. Looking at over the last 10 years, the numbers have varied, and they vary, as I say, between 9 and 20. And so 4 or 5 years ago, we might have had 20 again, and then a 13, a 14, a 9, and there isn't a pattern. It's remained between those two. So there hasn't really, there's no kind of, we haven't seen lots of increase at all, and the rate has actually come down per population. Although obviously we're talking about individuals, so it can vary, and there isn't really a pattern to it. I don't think, I'd say, in terms of numbers.
Thank you very much. So I just wanted to ask you, talking about online safety, and actually how that's quite important to suicide prevention. We've obviously got the online safety bill, which is being proposed. Do you think that will help? I'm just interested to hear your views on that, whether that will actually make a meaningful difference to some of the outcomes.
I'm not actually too familiar with the bill, I'm afraid. So I haven't looked at it in detail. I think anything that gets people talking to their young people around what they're doing online is a good thing. That'd be my first point, really. And obviously knowing what your child is looking at as well. I mean, the research has just come up a few years ago that a history of looking at these kind of pro-suicide sites, is one of the risk factors. So that's the thing that's risk, really, that we need to try and, to stop, really. So I think anything that does that in terms of legislation is a good thing.
Oh. I'm not sure whether I'm allowed to or not, but just to come back onto that point, having spent quite a lot of time with our child and adolescent teams recently, what they would say is it's not just the online access to awful websites where it tells you how best to kill yourself. I mean, that's how awful they are. They also give you the mechanisms to do that, where you can buy them and buy kits to your homes. So anything that you could do that could prevent those websites would be helpful. But I think it's more, it's in parallel to that. It's also the constant cyber access, the constant access to social media, the inability to switch off, to move away, and also for young people actually hearing about the levels of self-harm that other people are engaging with is quite prevalent on these websites, and fairly competitive. And actually, Daniel spoke about the correlation between self-harm, between women self-harming and actual completed suicide. And there will be a number of accidents within that, that we can't be naive to.
Thank you. Daniel, you were saying about the age range for the men. I think it was 40 something. I was quite surprised because I thought maybe it's recently during the COVID. I thought it was younger, sort of from about 18 to about 29, 30 for the men. Am I wrong?
That's nationally that the middle-aged men is the kind of the biggest group that die by suicide. Locally, we did our in terms of we did our audit in 2017, and again the largest group there were middle-aged men. So we've done that. We have had a more recent information. We work at South West London level, and we have what is called real-time surveillance, and this is used really for to support families in terms of bereavement, in terms of identifying families. So, and there's got to be the caution around saying this, because firstly, the numbers are very low in terms of the period and the time shot period is between April 21 and February 22. Secondly, no coroner has actually said it's a suicide, so it's just a police suspected suicide. So those are the kind of cautions around it. But that found for Merton, and numbers are quite low, we had 47% were aged 30 to 59, which is the largest group. 29% were aged 20 to 29, so that is quite a fair bit of younger people as well. 12% were 60 plus, and 12% were 17 to 19. But the numbers are low, so the percentages might be slightly larger. So just that's a kind of a health warning, but that's a kind of a snapshot of less than a year's data really. So there's a lot of caution around interpreting that. So I think middle-aged men are still one of the largest groups, but obviously there were quite a few suicides of people aged 20 to 29 as well.
And how do you say you support families? How well do you support the families? And how long do you support them for?
Yeah, certainly. So we've commissioned South West London ICB. We work across South West London and have got NHS funding for bereavement support. So they work with families who are obviously the police have identified, and that support really can go from it can go for quite a while, and it can go up to support what's going to happen to the coroner and all those advice, and they signpost to other organisations, but they also are offering peer support as well. So a lot of people who have obviously been bereaved by suicide find quite difficult to speak to someone who hasn't gone through the same experience, and they've found it really, really helpful just to talk to people who've been through the same experience as them. So and those groups are ongoing at the moment. So the project is ongoing.
Thank you very much. Anybody else have any questions for Daniel? Oh, Caroline.
Yes, thank you for your presentation. I was going to ask you, you were saying about middle-aged men, and I was wondering if the ease in which they can gamble now, both online and even in betting shops, if that has had any effect.
I don't know the data on it, but there's been a couple of national research things that have said it is a risk factor, and I would think it is. We have been talking about it at South West London level as well. Obviously, the risk factors around debt are very closely linked to gambling. It's an addiction as well, so that might be quite linked to that side of things. Keeping things quiet as well. So these are all kind of risk factors that relate to suicide. So yes, definitely, I would say it's an issue.
Thank you. Anybody else? Oh.
I just wanted, for completeness, also draw some attention to London work, because obviously each borough has their own plan, but then we work across South West London and we work at London level. And you might have heard about Thrive London, so that is the mayor's a big sort of mental health movement building, a lot of preventative stuff, and suicide prevention is one of the big planks. And what you possibly have come across, but we certainly use, is Thrive London is very responsive to contextual stresses. So when the war in Ukraine broke out, there were quite a lot of communities really affected. And Slavik, you probably have a lot more first-hand experience. And Thrive London helps with really informing and raising awareness. And then obviously most recently we've all been seeing with horror the tragedy around the earthquake. So there are communities again that are particularly affected, and so Thrive London helps us to raise awareness and signpost communities to help, but also help us to frame what support is around. So I wanted to draw attention to that, because we are contributing to that. There's also the mental digital program Good Thinking, and you might all just give it a go on your phone. So this is an accessible digital mental health program for anybody in London, and it is has different modules. So obviously digital access is not for everybody, but on the other hand, for some, it lowers barriers, and it looks at anxiety, at stress, at sleeplessness, and it is quite nuanced now, that it responds to if people search on their computer, I can't sleep, or I feel so low, as we've just talked about digital, then the Good Thinking pops up and says, have you tried? So evidence program, we've developed it together at London level, and we're supporting it. And if you can promote it, because it's obviously totally free of access. And then thirdly, just because obviously every death is such a tragedy, there's a specific piece of work that the London Health Board has initiated, and through my role as sort of lead for children, it looks again at infant and child deaths in London. And that includes, initially the scope was only for infants, so under 1 year, but we very much pushed and said we want to have the whole spectrum of children, so that we are also capturing suicides. And you will be aware each child death has a child death overview panel, so we've got some really in-depth data. There's a national child death database, and so we're doing more learning and understanding from these very tragic individual cases to think, what can we do jointly to prevent? So just to give you a flare, that outside Merton, we also do lots of work that hopefully benefits Merton residents.
Sorry, just one final question for me. So I wasn't really sure whether sort of to mention it, because I don't know, but it'd be quite interesting to see in the numbers. So when I used to sort of look after sort of the healthcare sector professionally, groups of pharmacists would actually say that there was a demographic that were more impacted through mental health, and even suicides could be higher. And it's actually wealthier demographics. Actually, they found they were dispensing more mental health medication in sort of pharmacies, and so they could sort of tell what some of the issues were just from the location of where the pharmacy was and what was the level of dispensing of those medicines were. So I just wondered, there must be certain aspects that are, or certain, maybe potentially certain demographics, when you look at sort of how pharmacists are dispensing medication, which might help us build support groups in the right areas. Because it seemed to be, just from what we saw in the private sector, there was some kind of locational aspect to it as well. Now, it looks like you might disagree with that, but that was the information at the time that they said to me, that there was a sort of clear demographic evidence.
So I agree and I disagree. So I think one of the key factors for successful completion of suicide is access to the ability to take your own life. And often, if you are dispensing large amounts of drugs, that will give you access to life. But also there's different, there are different professional groups. For example, medicines, dentists, pharmacists, they have a higher prevalence of suicide when you look at it statistically across the country. There are pockets as well around those in the most wealthy communities, as well as those in the most neglected communities. So unfortunately, there isn't one pin that you can point it to. But certainly one of the things that's great is that the work that we're doing across the suicide prevention, it takes into account all of the different factors, so that one community is not left at risk. So I wouldn't say it was an affluent thing or a poverty area. I would say there's a number of factors that would connect together from my experience within secondary mental health.
Anybody else with anything? Questions? No, thank you, Dan, and thank you, Dagmar.
Thank you.
I think you're all free to go if you wish.
Oh,
Not you.
I thought you were closing the meeting.
No, 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 no. They're saying if they wish to go, because we've got our cabinet member next. Or did you want them to wait?
Yeah, I think our colleagues have done a long day and they deserve to perhaps say hello to their families before they all go off to bed.
I agree. Thank you. Right, Councillor McKay, cabinet member, can we have your?
Thank you, Chair. When I took on the responsibility for health and adult social care, it was 20 years after I'd last done this job. So you could describe me as the comeback kid. But what I was immediately struck by when I got the briefing from John and his senior team was just how much things had changed during that period. For a start, it was just adult social care back in 2001, and health is an additional responsibility. And they gave me a briefing which ran to several pages, and I found myself taking a very deep breath and thinking, "Oh my God, is that all under health and adult social care?" So I thought it would be helpful in the first slide, but without going into discussing each line of this slide, just to give you an indication of the responsibilities there. And I think it's important to recognise that we do have statutory duties that we have a responsibility to perform. And there are a whole range of different groups that we have a responsibility for. The other aspect of it, of course, is the size of the budget. It's 60 million for adult social care, 12 million for public health, which also comes in under this area of responsibility. And that's a big chunk of public money. It's a big chunk of the council's overall budget. And I'm very aware of the responsibilities to remain within budget, but recognise the challenges of actually meeting your statutory responsibilities whilst trying to land the plane on a very short runway, because what we don't want to do is overspend, because that has an impact on other departments. But what we do need to do is deliver quality services. So I'm not going to go into any more about that, because what I was asked to talk about was my priorities. But if we go to the next slide, there's the responsibilities of public health. And again, these are very much summarized responsibilities, but there's an awful lot to that as well. And again, I'm not going to spend too long, because if I were, as I did for a number of years, chairing this meeting, and a cabinet member came along at this time of night and started blethering on, then I would soon tap at my watch and make it clear that they needed to move on quickly.
Sorry, actually, we will actually leave you behind.
Sorry?
Leave you behind if you're still wittering on.
Well, that's good to know, Agatha. Thank you. But here's a couple of slides that I think actually gives you a picture. And it's interesting actually, because Vanessa did the same, adopted the same approach earlier on by giving you some numbers. And here are some numbers for adult social care on the next slide. Again, I'm not going to go through each line of that, but it does give you an indication of the sheer scale of activity that's going on. I think it's worth me referring to, total numbers, but the third bullet point, Mascot, is a service that I think John and I are very proud of. I spent some time the week before last, working with the mascot team and actually going out. And to those of you who are not familiar with it, it's the telecare service. It's something that my father benefited from in his final days when he had vascular dementia. And I think that the best way to sum it up is peace of mind. If you've got somebody who is vulnerable and they're living alone, then having a means of summoning help instantly if there is a problem is a huge weight off the mind of the individual and their carers. And I really was impressed with the service that we provide, and the fact that, you know, if on the morning that I went out, there had been 4 people that had a fall, and the staff had been out there very quickly. And, you know, it really then depends what the circumstances are, what follows. But such a simple but important service, reaching out to a significant number of residents, and a very important service. I'm not going to go through each one, but if we can go on to the next set of numbers, you can see there yourself. Again, it gives you an indication of the range of people we provide support to and the things that we get up to. You know, there's an awful lot of big numbers in there, and that perhaps explains the size of the budget, which, as I said earlier, is 60 million. So the thing that you asked me to do, Chair, is to talk about my priorities, and so the next slide deals with that. So I've put that last. A really big issue is tackling health inequalities. I find it unacceptable, and I think most people here find it unacceptable, that the difference between life expectancy amongst our citizens in different parts of the borough is so marked. And I'm determined to address that issue. One of the priorities for me is maintaining all services at St Helier Hospital. Vanessa earlier on referred to an anchor institution. And an anchor institution, she described the Mental Health Trust as an anchor institution. She described, you know, the impact that it can have on the local community. And the St Helier estate, built at the end of the 1950s by the London County Council to rehouse people who were being moved out of slums in central London and found themselves in what they believed to be a paradise with lots of green spaces and lovely new houses, and a hospital, a local hospital that they could rely on, has been really valued and treasured. And it seems to me perverse to move a hospital from an area of deprivation to one of the wealthiest parts it is just inside Sutton, but it's as close to Surrey as you can get without actually being in Surrey. It's an area of affluence, and it, as I say, it seems entirely perverse. And for me, because I represent Ravensbury ward, I've timed the journey on foot, walking from Newhouse Walk, which is the nearest point in our ward, and I referred to Caroline as well, to the front door of St Helier Hospital. It can be done in about 10 minutes walking. It's going to be a very different situation if that hospital moves. But the other thing that in relation to health inequalities, I also have an issue about the way that things have been done in the borough, because our colleagues in health talk a great deal about tackling health inequalities, and I have said to them in various meetings that they'll be judged not by what they say, but by what they do. And when you think about what's happened over the last few years in relation to primary care, and secondary care. The Nelson Hospital I think the nearest station is Wimbledon Chase, and it's in Merton Park Ward, I think, although the boundary changes have probably affected that. But that was built in an area where we have amongst the highest life expectancy, something like 17 years ago, and yet the people looking to similar services in the east of the borough are still waiting for the creation of a health and wellbeing hub. Why is that? And how can that be justified given the health inequalities and the need to tackle them? And similarly, we had at the Wilson Hospital, there was a surgery a few years ago that was closed down with very short notice, and people were moved to surrounding GP surgeries, and they were told that these surgeries had plenty of capacity to take them, but it turned out that they didn't, and some of them, having got to the list of surgeries provided, were turned away and had to go, going from one to the other to find a doctor to treat them. And that has happened with the Rowan surgery. It was closed recently at very short notice. And when I looked back, I discovered that it was initially considered unfit for purpose about 15 years ago, and that money had been provided to rebuild it by the NHS all that time ago, and yet nothing had been done. And that surgery was practically falling down when it was closed at very short notice. With the Colliers Wood surgery, a contractor was supposed to be starting work within days, and the contractor basically pulled out because they wanted more money to deliver the service, the building that they had been commissioned to build. And we still don't know exactly what's happening with that. And before anyone runs away with the idea that I'm only interested in primary care in the east of the borough, I think if you talk to former councillor Una Moulton, she will tell you that I took exactly the same view when a GP surgery was closed at very short notice in Wimbledon, in the ward that she used to represent, because to me that's unacceptable, and people struggle to get GP appointments, and if you reduce the number of surgeries, then that's not good news. So I am holding the NHS to account with all of these things, but there is some good news in that at the Wilson Hospital, we've been in discussions with the NHS, and money has been made available, and there is a plan to develop a health and wellbeing hub on the Wilson site, and I've been told we will have a conversation about providing the same range of services in that hub as exists in the Nelson, and that includes diagnostics. I've been to the Nelson to have outpatient appointments there, and that's the sort of thing that I would like to see in the Mitcham Health and Wellbeing Hub. The next priority is the provision of high quality services on a best value basis during inflationary times. And that's, again, quite challenging because we want to deliver the best possible, but we have to work within a budget. I take pride in the fact that in my career as a chief executive of a voluntary organisation, in the 20 years in my last job, we managed to come in better than budget on 19 occasions, and I think that's a responsibility that I take very seriously, recognising the need to meet the needs that we are obliged to provide to our citizens, and inflation is at the moment creating even more challenges for John and his team as we try and budget and plan for the future. Safeguarding vulnerable adults is a particularly important aspect of our work, and that has to be a priority. We are developing plans for improving services for people with a learning disability, which will involve the provision of a new day centre and supported living accommodation for many more people with a learning disability. My experience of carers and parents in particular of people with a learning disability is one of the biggest worries they have is what will happen when I'm no longer able to cope with looking after my son, my daughter, and that may be because they're physically no longer able to cope, or of course, they worry about what will happen when they're no longer around. Who's going to care? And so the idea of providing supported living that people can move into and settle into and have a life that's not too dissimilar to the lives that the rest of us enjoy is really important and greatly reassuring for carers. I've got a responsibility for food poverty. I spent some time yesterday talking with the amazing voluntary sector groups within Merton who are providing food banks and the community fridge. And part of my kind of role there is to, within the cabinet, ensure that we allocate resources to these really important groups, particularly at this time, but also to kind of monitor how they're getting on and whether the donations that they're receiving are matching the food that they're distributing. And and that's something that I think we have to keep a really close eye on as we go along. We will, for the first time in a very long time, it did used to happen, but then it stopped, be inspected by the Care Quality Commission as a department, and we will be assessed and judged. And that's anyone who's been involved with a school will tell you what Ofsted inspections produce in the run up to them. People get very anxious and they're desperate to come out with a good grade, and that's no different for us, and that's one of the responsibilities that we will be having and facing in the coming months. And the final thing to talk about is the recommissioning of the home care contract. This is going to be a big priority for us because it represents a really important aspect of the work that we do. Home care is all about keeping people in their homes, their own homes, for as long as possible so that they can retain their independence. And again, who wouldn't support that objective? But we do that by commissioning at the moment a number of companies to deliver that contract. It's worth a huge amount of money. It's currently about just under 10 million, and we are about to tender for a 5-year contract. So I'm really conscious of the public money that will be involved in that. It's going to be in the order of 56 million over that 5-year period. We have a responsibility to get the best possible service. But one of the things that we are determined to do is to pay the London living wage to those contractors, because we hear so much these days about the importance of recognizing people and the difficulties that people working in social care are having in terms of recruiting. And I think it's very important that we send a very clear signal that we do value the work that such workers do and deliver. And so that will be an obligation of the contractors that take up this work, and that will cost more money. But I think having principles about the need to pay decent money to people doing very difficult work is a price worth paying, and sometimes principles cost money. So I'll leave it at there, and I'm happy to answer any questions that members may have.
Before you start, can I just see if John's got anything quickly to add to it? You've got 2 minutes.
I've got nothing to add. That was a very comprehensive presentation,
Okay.
Chair.
So just a very quick question. So very interested, because obviously I know the good news that paying London living wage. I understand that sometimes with care, that part of the problem is that obviously we don't pay for travel. So care workers will then, if they're doing domiciliary care, they will decide, okay, well, I'll do that or I'll do this based on how far it is for me to travel. Have we considered about whether we can cover costs to actually accommodate kind of that travel aspect, so that then you don't have certain areas being disadvantaged?
I'm pleased to say that we are building in travel costs and travel costs and time for people between. Now, that doesn't include if somebody chooses to work the hours where they might have sort of childcare responsibilities, and if they're going to do a call and then disappear for a couple of hours, we're not going to pay them to go home and then come back, but we will be paying, yes, and that's built into the tendering process, and I think I sense you are supportive of such a thing, so yeah, thank you.
I think we've got Lola wanting to ask a question.
Hello, can you hear me?
We can hear you.
Okay. So it's really a shock to see that some GP are closing down within like a short notice. In terms of reallocating some of the patients to other GP, I believe that some GP have a rules that you need to live within like a mile of that area. So what happens to those people that they don't live within that area, or they're too far away from those other GP? So how will the GP be like accept them? Do you know of any support in that for them?
John, do you want to answer that?
Sorry, Lola, I'm not sure I got the full question, but I think it was about, is the question about the closure of the Rowan's surgery and the movement of the list of about 8,000, 5,000 patients to different GP surgeries? Is that right?
Yeah, that is the question. And then also some GP said you need to live within a mile or within the area of where that GP is located. If the patient that you are being allocated to another GP and they don't live in that area or close to that GP, will the GP still accept them, or will they have to keep looking for another GP that will accept them?
So I think that I mean, I'm not a health person. It would be a question for the ICB, and I think that Stella, we can request that full details from the ICB to answer the question properly. The ICB have been working with the patients to ensure that they're moved to correct surgeries. There is choice within that. They check to ensure that the surgery has the capacity, but there is choice for the resident patient to be able to choose the surgery they really want to go to that's closest to them. I think, though, that question really is a health question, and I think that we'll get the details from our ICB colleagues and a written statement for the panel members, if that's okay.
Well, if I can add, Lola, I think that is a good question. And actually, when I was told about the closure of the Rowan's surgery, that was one of the questions I put to our colleagues in the NHS, because it's really important that if you're going to tell people at short notice that your GP surgery is closing down, that you are given immediate reassurance that other doctors will take you, and just as important, actually have the capacity to take you. And they gave us that assurance when we first discussed that with them. I did remind them that in respect of the Wilson, which was a few years earlier, that those assurances had been given then. And when it came to it, there were people that were turned away from surgeries, which was completely unacceptable, I think, to all of us. So, but I think we can get further information and get the answer to that question to you from our colleagues in the NHS.
Thank you.
Thank you very much, Lola.
Thank you very much, Chair. I've just got a couple of comments and a question. My comments are really pleased to hear about the London living wage. The half a dozen motions that my group has put on this over the last couple of years, last few years, have finally taken effect, which is great. On the Nelson, just an observation, which is, I think it's important not to underestimate how the Nelson was brought about by a group of GPs who saw an opportunity for that building and both decided to move their practices in there and come up with some innovative ideas. I'm biased because my wife is one of them, but I do think that being driven by the GPs was very important there. And my question comes down to the issue that we discussed at the last one of these meetings, which was the £330,000 of savings, which we didn't have any detail of. And we said, and we agreed would be given more detail at the Overview and Scrutiny Committee, which I know Councillor McCabe attended. In the Overview and Scrutiny Committee, they had, via the Equality Impact Statement, a little bit more information, but it's still pretty general: efficiencies in overhead, service transformation, opportunities for service integration. And I just wonder if Councillor McCabe is now happy that that 330,000 will be delivered without affecting adversely any services. Thank you.
I think the first point is the London living wage. You know, I'm aware of a number of motions that have been put forward, but there are some of us who've had a commitment to that, which goes back far longer than that, and my commitment to paying workers decent pay is a lifelong commitment. I'm proud to be a trade unionist, and I have fought for good terms and conditions for workers in my entire life. So, you know, if you think that the Liberal Democrats putting a motion down is what's caused that to happen, then you know, you are puffing up your own ability to influence what's going on in this chamber. Those are principles I think that we share, and we shouldn't be trying to have a competition. If we share them and we can achieve that, then we should congratulate ourselves as a council. And you know, I think it's foolish to be getting involved in a game of one-upmanship. The thing about the Nelson is, and the point I was making, I think, is in a situation where there are health inequalities, is it right for the NHS to allocate resources on the basis of who has the loudest voice, by having a highly organised group of GPs wanting to deliver good services? And don't get me wrong, I'm happy that people in that area have good primary care, access to good primary care, but the decisions about the allocation of resources should be based on need. And those that needed that kind of hub most at the time that the Nelson was built and the NHS resources were provided were the people that suffer from health inequalities. So my question to the NHS, my challenge is, why can't the people that suffer from those health inequalities enjoy the same service that exists elsewhere? And sorry, what was the final one, Simon?
No, thank you for that. The final one was about the 330,000 savings that you discussed at the OSC. And if you are now happy, we can do that without any adverse consequences.
Well, I think what was clear in the last meeting of this panel was that people didn't feel they had enough information. I have provided them with we've provided an equalities assessment which lists the kind of work that the funds from the public health budget will be supporting in the voluntary sector. And when I went through that list in overview and scrutiny, I thought I'd made my position very clear that I was proud of our support of those voluntary sector organisations. And in fact, Vanessa, who was with us earlier on, I spent some time with her just before overview and scrutiny. One of the comments she made was that she's very keen to put money into the voluntary sector because she believes that often that can achieve better value for money because the sector is often more innovative and nimble because it has to make the money go further. So, one of the questions I put to one of your colleagues was, which of those voluntary groups did you not want that funding to go to? And the response was deafening. The response was silence. I am confident that this is the best use of those available resources. And I think I come back to the point that I made in terms of one of my priorities, which is to deliver quality services within the available resources. And that's not an easy thing to achieve. I have served in opposition on a number of occasions, and I know how easy it is to say, oh, you shouldn't be doing this and you shouldn't be doing that, when you don't have to come up with alternatives. It's far more difficult when you actually have the responsibility of managing those budgets. And I get the fact that oppositions will criticise without having to be constructive, but I am satisfied that that money is being properly used and is being used to best effect.
Just a point of clarification, we don't have any problem with the money going to the voluntary organisations. The concern we have is that the £330,000 from which it is being funded, it's not at all clear how it's being funded and what effect that will have. So we just want to have it on record. No problem with the money going to the voluntary organisations. We're still not clear. We understand what's being cut to fund it and what effects on services that will have, because in the papers that went in the equality impact assessment, there really isn't any detail. I just wanted to get that on record. Thank you.
Can I just clarify as well? We're not planning any cuts within the public health services to any of our services. We are planning to redesign some of our services to do things in a more efficient way. The same services will be provided. I would not have put the saving forward if I didn't think it was doable, if it was suitable to do it. And there are no planned cuts to the public health budget. Those services will remain. The only thing I'd like to add as well, it was a comment that you made about the Nelson 15 years ago. East Merton GPs did the same thing with the Wilson site. The money wasn't forthcoming. We haven't got any NHS colleagues here, but they would be the first ones to admit, they've told Councillor McCabe and myself, that was an error. That was not correct. And that's why they've given a commitment to rebuild the East Merton hub at the Wilson. That commitment is now there. The money is there. Hopefully it'll be built within by 2025, along with a commitment to the Rowans, which is another site that Councillor McCabe mentioned, 15 years at least, that it's been deemed as unfit, and it was closed as an emergency, a commitment to rebuild that, and Collier's Wood, to make up for that 15 years of lacking of funding. Again, I'm not apologising for the NHS. I don't work for the NHS, but they would be the first ones to say that was an error, which they want to correct.
Thank you. It was an error. They promised to do Wilson first. I was part of the campaign with Siobhan and Latchman, and they didn't do it. They went to Nelson. Yeah. Anybody else with any questions? No? Well, thank you all very much. We've got the work programme is just to be noted. Next meeting, we'll go over the priorities of the work programme for the coming year. So thank you all for your time, your patience, and have a good evening.